So welcome to the first webinar on our heated high flow nasal cannula oxygen therapy update. My name is Ryan Trudeau. I'm a registered respiratory therapist, charge therapist at London Health Sciences Centre.
And my name's Andrew Latchman. I am a pediatrician at McMaster Children's Hospital. Excited to be here and with all of you today.
All right, so there you go.
So just to kick this off, Ryan and I are presenting today, but we're really presenting on behalf of a lot of people who put a lot of work into this. Multidisciplinary, tons of engagement across OH West and subsequent engagement from other stakeholders to give us great feedback to land on what we have put together today. So a big thank you to the Ontario Health West Clinical Quality working group members listed here. Won't go through all their names. Special acknowledgement as well to Christine Fraser as well as Kendra Savage, who did a ton of work compiling all of this information into a digestible, efficient format that we're going to present today. So many thanks to everyone involved in this great work.
Okay, so with that, thank you everybody. We're going to jump right into our presentation today, and we're going to start with what is high flow. So it is essentially a device that will now blend medical air as well as oxygen together. It delivers a dry gas that once used to be coming out of the wall into a warm, humidified therapy that meets or exceeds a patient's inspiratory demands. With the use of various nasal interfaces, so pediatric and adult sizes, which should not exceed 50%, we are able to deliver a precise level of oxygen with optimal heated humidity, so 100% relative humidity provided with these devices. And it's able to assist our respiratory patients with mild to moderate respiratory distress. One of the key benefits of high flow is its ability to wash out anatomic dead space. So it essentially clears the upper airway and promotes fresh gas being readily available for each inspired breath. With that, it is known to decrease work breathing and decrease respiratory rate on our individuals in respiratory distress. The heated humidity prevents the drying of the airway. So those nasal cannulas that we have used without humidity for all these years, we're now able to warm and moisten the gas, provide airway clearance benefits, as well as keep the mucosa nice and hydrated. Because of that, it's also well tolerated and very comfortable for your patient, and it can bridge that gap between low flow and non-invasive ventilation if you are able to provide that at your center.
All right. Thank you, Ryan. And so I really want to highlight and emphasize that last bit that Ryan touched on in that bridging a gap, because when we approach this, we wanted to make it as evidence-based as possible. So we conducted a literature review. We looked at articles, and we really looked at articles focusing on the community, because that's where we wanted to put the emphasis here. That's where we wanted to put the support. We also wanted to look at its use, how high flow was being used in the Paris trial, Paris 1 and Paris 2, probably the most comprehensive trials out there looking at it in a slightly older population than I think the majority of our patients fall under, but still excellent literature. The focus on the bridge and the focus on the high flow, and we'll go through it in the subsequent slides. High flow isn't meant to be a replacement for low flow. And it's almost, I come from a time when I started training, there wasn't high flow. It wasn't ubiquitous. Then some places were using it in the level 2s. And then all of a sudden it became the thing to use. And so we're going to move on to the next slide, but I want us to keep that in the back of our minds, that it is a bridge between low flow and more invasive ventilation. And it's one of the tools in our toolkit, does not completely replace all of the tools. Next slide, Ryan.
Yep. Okay. So on this slide here, it is busy looking, but this is essentially the algorithm that we as the Ontario Health West working group came up with. So what we're going to do in the next few slides of the presentation is just really dig into this algorithm and how you can implement it at your site. And we'll take you through it step by step using a case scenario format.
Okay.
Andrew.
So we start with initiation. And when we start with initiation, I don't want us to forget that there is low flow oxygen. So infant with ongoing respiratory distress, TAL score, I'm not that quick, Ryan.
Yeah,
TAL
sorry.
score greater than 5. Now, if you have another scoring tool, we'll talk about the TAL score in a soon slide. You can replace it, but we thought that is the best evidence-based literature out there and easiest to use and implement. Hypoxia, SATs less than or equal to 92%, or target saturation rate for age, despite low flow greater than age-defined recommendations, or FiO2 via Venturi mass greater than 40%. Emphasis on despite. So we can still use low flow. We want to use low flow. High flow is fantastic, but we don't want it to replace and be all the end all, because there are subsequent impacts on feeding, length of stay, potential, although not borne out in practice, complications of use of high flow. These are things we all need to consider. It is a form of ventilation. Next slide.
So this was actually supposed to, I believe, there it is. There we go. Okay. Sorry. I was thinking that, yeah, sorry, I'm getting trigger happy on you here, Andrew.
It's all good. It's all good.
There we go. Let's go back to that slide.
Here's our clinical vignette. Call to the emergency department to assess a 4-month-old infant who was brought in by parents with a 3-day history of fever, rhinorrhea, nasal congestion. Today, parents state baby is more sleepy, not feeding well, and has increased breathing difficulties. The baby has an unremarkable perinatal history.
So you do your vitals and respiratory assessment, and this is what you come up with. You have a heart rate of 185. Your child is tachypnic with a rate of 70, BP 75, 150. A is febrile with a temp of 39. Your SpO2 is 86 on room air. You noticed nasal flaring, expiratory, and inspiratory wheezing upon auscultation. And you also notice that you have some moderate intercostal and subcostal retractions. You also do a cap refill, which you find to be 4 seconds. The child is pale and pink and worn to the extremities. So what is your plan? So most of the time, you're probably going to start this child on some form of low flow nasal cannula therapy. So for your smaller babies, you may have the option of using the ultra low flow meters, which are able to deliver O2 between 25 and 200 mils, or you're going to use your standard low flow, your standard oxygen flow meters that deliver approximately up to 15 liters per minute of FiO2. What we do have is some recommendations for your max O2 flow rates for nasal cannula when you're just using standard oxygen therapy. And those are 1 liter, approximately 1 liter per minute, to a maximum of 2 liters. Again, we're talking about delivering dry gas here to these children. For your larger child, no more than 4 liters. And those are children generally over the age of 1. And consider starting high flow when you're getting close to those max rates. Especially in those older children, consider it around 3 liters per minute. And again, it's all about comfort and also the additional benefits that high flow can provide. Okay.
Okay, here's the TAL score. And again, probably new to many of us, but when we look in the literature, when we look at ease of use, this is probably the best way to standardize our assessment in infants with bronchiolitis. Many places use PRAM in asthma, so this for the bronchiolitic population can really help guide our degree of concern and help us put it into a category. So we're going to look at respiratory rate. We're going to look at presence of wheezing or crackles. We're going to look at saturation in room air. Note the little caveat: if you're on oxygen when you're doing the assessment, you automatically get a 3. And then accessory muscle use. Of course, no score is perfect. What looks like mild or moderate to someone with varied degrees of experience will change, but hopefully it reduces the degree of inter-rater reliability, or increases the rate of inter-rater reliability in terms of assessing clinical state. So let's calculate a TAL score. Okay, Ryan, maybe hit the other button to get us to, because we have SATs on room air.
Yep.
Then the next one will give us our assessment. So we'll be able to come up with a score. So take 30 to 45 seconds and maybe pop into the chat what this infant's TAL score is. Remember, it's a 4-month-old, so age less than 6 months of age. See, we were tricky. We gave you a lot of information, just not just what you need. It's everything you will have. So you have to kind of sift through a little bit there. Okay, I don't know. Can I see the chat?
Nothing there yet, I can see.
Nothing yet. Okay. I guess the next step is to come up with an app. Oh, Lindsay, first in a 9. Solid. We get 3 9s, and then it's like lucky 7. We win the jackpot. Oh, that's the same person. Have consensus?
2, 4.
All right. Lucky 9s. Jackpot. Next slide.
Yeah, so there 9. You go.
Boom. We're all experts. Nobody needs to worry about the TAL score anymore. Next slide. We all have it memorized.
Okay, so I think that's a great starting point for us to now leap into this algorithm. We're using that validated tool that Andrew just spoke about with you guys, and now you're at the bedside with your patient. Your doc is there, your RT is there if you have one, and now you're saying, do we or do we not start high flow? So what you want to do is with your team, look at your indications, contraindications for high flow. So things like type 1 hypoxemic respiratory failure with underlying pneumonia, bronchiolitis, asthma. Those are all great indicators. And is there anything that is contraindicated? So, things like nasal fractures or facial trauma, that might be a relative contraindication to that. Some absolutes are like choanal atresia, history of or has a pneumothorax. That might be a contraindication that you are concerned about. Once you review that, you want to evaluate your patient. So go back and reevaluate their heart rate, their respiratory rate, their blood pressure, work of breathing, and their SATs. So in addition to that, if you have the capability, we do highly recommend initiating cardiorespiratory monitoring, and then initiate your high flow based off the table that is highlighted here on the screen. So this is a weight-based validated recommendation from the Paris 2 study, looking at weight ranges. So anything between 0 and 15 start at 2 liters per kg. 16 to 30, we're recommending a 35-liter start, and so on the screen there. One of the things as an RT and that I found over the years, it's not always the best thing to start right at that 2 liters per kg or that maximum flow, initiated flow. Start low and work it up, work yourself up slowly to that recommended flow. Let your patient acclimatize to it, okay? Once you initiate it, again, whatever your SAT target is, or is it greater than or equal to 92? Again, you could have a specific scenario where you might have a more specific targeted SpO2. Okay, once you start it, reassess your patient. Most patients will respond very well within the first 20 minutes of initiation of high flow. We're recommending that you definitely are reassessing them within that first 30 minutes, reassessing their heart rate, respiratory rate, blood pressure, work of breathing, and SpO2. Okay.
Okay.
Case review. Andrew, there you go.
We have started the high flow, and we're reassessing 30 minutes later. And these are our current vital signs. I appreciate that I don't have let's assume the same clinical findings of moderate retractions and wheezing present on the stethoscope. Is this patient improving? Fire that into the chat. No, Andrea. I concur. Who else concurs with Andrea? Are there any other? Yes. So really, and honestly, right, you're sitting there, you're looking at that 40% is a nice bar, especially out in the community, right? If that oxygen need isn't coming down, if the respiratory rate isn't coming down, if the degree of work of breathing isn't coming down, we need to act. All right. And so this is the right-hand side of the algorithm. And we escalate the respiratory support as per the hospital policy. So we recognize that depending on where you are, there may be flex to go up with degree of that, with the degree of high flow support in accordance with your team. And so we didn't want hospitals to feel like, or teams to feel like, they needed to call and activate critical right away. But we also recognize not every center has a level 2C or a level 3 down the hall. And so we want people to call and engage early if infants aren't getting better with escalation, because we don't want the deterioration to happen in a place where other supports cannot be implemented to prevent, say, intubation. So we can go more invasive, but not all the way to intubation. So escalate respiratory support as per hospital policy, and or activate critical based on your hospital policy and capacity.
Okay, so
Okay.
there
So
you go.
now we have a different scenario. So we reassess 30 minutes later, and our FiO2 comes down, our respiratory rate comes down, our TAL score is improving, our work of breathing comes down. In this situation, okay, is the patient improving?
Yep.
And we say yes. So we're going to reassess. The key here is reassess. We're not just starting someone on someone and walking away for 24 hours and coming back. We're reassessing at 2 or 4 hours or sooner after initiation, RT or RN to follow up every 4 hours and as necessary while on high flow.
Okay.
Okay, so we continue to improve. And so now we work down the algorithm and we get to.
Are we improving or not?
Oh, sorry, we continue to
Sorry.
improve.
Yep. Sorry.
Right? Yeah, that's okay. We're continuing to improve. So now you can see we're on 30%. So I love the green. Okay, so we've been on high flow now for 8 hours. Look at that respiratory rate. That's a lovely fall, right? Is everybody seeing this? Is everybody buying what we're selling? So this is where, and this is the tricky part, right? Because now you got a patient who looks good. That patient came in and we were all very uncomfortable. We were all very uncomfortable. Now we're comfortable. But now we have to consider, what do we do next? And this is where we hope that this pathway will help guide you and provide some of that support, because once you get to this place, you don't want to change anything, right? But now we got to talk about length of stay, ongoing care, feeding, all of those different aspects. So we want to consider de-escalation. And this little box here on the side, oh, sorry, Ryan.
That's okay.
Everyone can see that. Just these are more signs of clinical stabilization. And again, other things to consider are ordering a gas, other signs, if this is more for deterioration, bradycardia, level of consciousness, worsening capillary refill. So our clinical stabilization is very clear, but there are other things that we would naturally gravitate to that would show a worsening. But in this case, we're getting much better. Sorry, Ryan, go ahead.
That's okay. I'm getting a little trigger happy here. All right. So moving on, we got that baby or that child that has stabilized nicely for us after initiation. We are 8 hours after that. We now need to start considering that weaning process. So you want to ask yourself, as per the algorithm, is my FiO2 now down to 40% or less? So on our reassessment there, our FiO2 is now down to 35%, and we were able to maintain our SATs greater than 92. But if you had that patient who wasn't able to meet those criteria, what we want you to do is just continually reassess your TAL score as well, and then maintain them on their current parameters, and reassess again no later than 4 hours, but preferably sooner if you can. Again, base it off of your workflow and such that's going on in your organization. Okay, if you are weaning and meeting the criteria that we had on the previous slide, you start wanting to wean your FiO2 first. Ideally, let's get it down to 30%. Keep that SAT greater than or equal to 92 or whatever your saturation target order is. And then once you get it down to 30%, start considering weaning your flow. So we broke it down into flows of, weights of less than 15 or greater than 15, and how to wean your flow appropriately. So less than 15, we're recommending half a liter every 4 hours until you're at 1 liter per minute per kg. For those children that are greater than 15, wean it wean it by 5 to 10 liters per minute until you're down to a lowest flow on your larger prongs of 15 liters per minute. Always reassessing your heart rate, respiratory rate, work of breathing, and again, your TAL score. Okay, so you've done some weaning and you need to ask yourself, am I able to continue to wean, or do I need to just stop, reassess, and maybe go back to my previously known comfortable settings, stable settings for your patient that was keeping them comfortable? Okay, so if it's a no, you're going to return them to those previous settings. And what we're asking is be patient, give them another 12 hours, and then try again. So again, these are for primarily those broncholytic children that you're going to see within your organization that you're probably keeping there. If your wean has been successful, you want to get them down to those recommended targets that we said, and then we recommend a trial off of O2 or to their prescribed home oxygen level if they are a home oxygen patient. Or you can trial them on standard O2 and then trial them off of that once you're able to maintain your SATs greater than or equal to 92% or that target as ordered by your MRP. Keep the high flow equipment at the bedside for approximately 12 hours before considering removing is what we're recommending from the working group. Right. Nursing considerations, so again, mostly clinical clinician considerations, again, depending on what your HHR are like at your organization. So we really want to emphasize those routine assessments. Again, good thorough respiratory assessments, continuous vital assessments. Again, skin integrity is something that we need to consider, especially for those children that may be on high flow for a period of time. The nasal prongs actually can cause some septal breakdown or skin breakdown below them. So it's a good idea as part of your routine assessment, check the integrity of the skin of the septal area, and always ensure that those nasal prongs are occluding less than 50% of the nares. Again, always titrate your FiO2 to keep your SpO2 within those ordered parameters. Continue to, as part of your respiratory assessment, we do consider and recommend moving your SAT probe to a new location every 4 hours, as probes can leave skin irritation marks to the children. In some cases, we've actually had instances of burns. So this is a good recommendation coming from the clinician side. I've also already alluded to the skincare, but again, pay real close attention to that nasal septum and those upper lip areas, again, for prolonged use, okay? But it's always a good habit to get into to reassess that with from initiation. Suctioning, again, we do recommend suctioning only as clinically indicated. We don't recommend deep suctioning down the nares routinely. Again, that can cause more harm and trauma to the patient than good. So there's certain ways that you can do it. You can use a catheter just to remove secretions from the nares, the mouth. You can use the little sucker or yonker. There's also the nasal tip suctions that you can purchase that again just occlude the nair and give you a good suction for clearing the nares that way rather than being so invasive with a nasal catheter. Always recognize that suctioning, depending on how deep you go, you may have a DSAT. Okay, so we don't recommend deep suctioning with these children. Again, you could cause a vagal response with that and then bradycardia, and we don't want to get in that vicious cycle. The other thing is we do recommend that you keep the nasal cannula and the oxygen tubing visible at all time. Don't cover them with towels or blankets. Keep them visible so that you can always ensure the integrity of the system while it's delivering therapy. Okay. Always, in addition to that, review your towel score. Again, that's a good indicator of a score that can tell you improvement clinically from your patient, obviously in terms of, so it's a validated score that gives you an objective validation versus subjective validation. And anytime that you feel you need to call for help, please call for help. And that is our presentation. Questions?
Got a solid 2 minutes.
There's a question in the chat, Andrew and Ryan, for the 0 to 15 kilogram patient group. What is your advice when or if considering flow rates above 2 liters per kilogram per minute, and to what maximum, keeping in mind the max flow allowed by the interface?
Yeah, I think that's a fantastic question. And that's why we said we really want to defer to your team, your hospital, and what you know. It's a very different situation if you have a level 2C or a level 3 immediate access and the ability to push that up in an area with limited resource or experience. That 2 is the trigger to call, because after 3, you're really heading toward that next step in care, which is the invasive route. And the difference between intubation versus CPAP or BiPAP is quite significant in terms of morbidity for that patient. So I would say the advice is to circle back with your team, circle back with all members, allied health, nursing, everybody, and visit what that is. There are centers that have that capacity to go up to 2.5, even 3. Sometimes you are forced to go to 3 despite comfort because there were no beds anywhere else. So it is that point saying, do I have the capacity to go up and not call versus I'm going to call, they're going to advise me to go up, and then we're going to have a plan in case that doesn't work, because that may get you to your place of stability. So you don't want to deprive the infant of that. So the call might be to critical. Yeah, we got to send somebody out. But in the meantime, we go up to 3, 2.5. I wouldn't go right to 3 from 2 to 3, right? I wouldn't do that.
Yeah.
Ryan?
And then John, yeah, you brought up a good point too. You want to always keep in mind that there are limitations to the interface that you're using, right? So again, if you're at the max flow rate for that interface, say if it's a pediatric extra large at 25 liters per minute, and you're advised to maybe try the higher flow while we send somebody out. Can you get an adult small? Can you bring in the double XL prongs for that patient? Again, those are where the RT's knowledge comes in again, but that's only if you have the luxury of having an RT there.
Great question. Speaking of RTs, happy RT week for all the RTs out there. Appreciate everything you do. You're welcome. Come on, anything.
Yeah, hit us.
Here.
Oh, there you go, Andrew.
Oh, here it comes. Aha. Stay tuned. That'll be the next webinar. We're working on it right now. I literally have a meeting in 13 minutes about that. Yep, you do have access to the slides. Carrie and Christine and Kendra will take care of that.
Sorry,
Oh,
my not working.
That's a solid question for you, Ryan.
Um,
XL dolphin prongs. Do you have any suggestions in dealing with rainout? And that's why we love RT.
yeah.
I really don't know.
Yeah, we're experiencing that too, Sean. It's just really being Being diligent to ensure that the prongs are not filling with water, and maybe as part of more regular assessments, just a quick disconnect to ensure water is being removed from them. Yeah, it seems to be an ongoing issue
Okay.
with how they were developed.
Right, right. And I think those prongs are MRI compatible too, right? Is that an issue with some of the other? Sorry for the technicalities and the technical questions here, but I'm curious
Those
for
are
some of the
because the pediatric ones are not, because of the metal
right.
that they have wrapped around it for keeping the heat. Those ones do
Okay.
not. Yeah.
Okay, great. Thanks, Ryan.
The other thing, Sean, is you can also manipulate your humidity down to the lowest setting of 31. I'm not sure
Right.
if you guys try that, but ideally
Yeah.
we like to try to keep it at the highest humidity heat setting for that benefit.
Right. Yeah,
It could also
usually
be
37 usually is what we put them on, yeah.
Yeah, and it could also be, well, in the well, yeah, you know what, it's
Juniors at 34.
yeah, that's what it's you're in adult mode for those, yeah, so yeah, you can't really adjust that. It could also be the room that you're into, right? The cooler the room, the more rain out you get out. We experience that in a couple of our rooms here as well. So it's just
Okay.
more regular assessments.
Okay, great. Thanks, Ryan.
Yeah, no problem,
Thank you,
Sean.
guys.
Nice
Thank
seeing you,
Andrew.
Sean.
Yeah, you too, Ryan.
Okay, well, it's 1:04. I'd like to thank everyone again for the time. Again, thank you again to Christine and Kendra and Carrie and the entire clinical work, and of course, Ryan. We're glad to be here, and hopefully everyone found this useful, and I wish everyone a great day.
Thanks, everybody.
Thank you.
Thanks, Andrew.
Ryan, that was awesome. Love
Yeah.
it.
Okay, we'll
Okay.
see you soon.
See you soon. Take care.
Thanks, Trubsy.